Hi, I'm Sue Kitchen. I'm the full CNC from Sir Charles Gardner Osborne Park Care Group. I'm here today to talk to you about vitamin D and its role in preventing falls. So today we're just going to learn more about vitamin D and the relation in falls prevention and bone health, look at some of the latest literature and then some take-home tips. So what is vitamin D? It's the oldest prohormone. It's 750 million years old, and a prohormone is a precursor of a hormone. So it's the substance that is converted into a hormone by the body. In the 1700s, they identified that cod liver oil and sunlight were known to be effective for rickets. It was first discovered in 2021 and it's named vitamin D because it is the fourth vitamin to be discovered. Deficiency causes rickets and can contribute to other diseases. I'm not going to go through this, but this is the story of vitamin D. So if you did ask for the presentation, you'll be able to have a look at it yourself. So it goes right back to the 1800s. So what's the prevalence? So around 31% of adults in Australia have inadequate vitamin D levels. 26% of women between 25 and 34 are deficient, but this does vary by season and by location. So in the winter, we don't have as much sunlight, so you maybe have lower vitamin D levels just for the winter and they come back up again over the summer. One study found that 61 to 100% of African refugees in Melbourne, Adelaide and Sydney had low vitamin D levels. This is often because they're coming from low socioeconomic countries. They may have dark skin, which reduces the uptake of vitamin D. And they may have had poor diet as well. There was a study done around some children in New South Wales, 398, and 9% had severe vitamin D deficiency and 52% had mild. So it's still around. The prevalence of vitamin D in Aboriginal health. There was one study, and this was done around 2011, 2012, and there were 529 Aboriginal participants, and 31% of them had greater than 50 serum level of vitamin D. It was independently associated with diabetes and cardiovascular disease was increased with the low vitamin D levels. However, a more recent study that was just published on the Aboriginal Infonet shows that most Indigenous Australians do not need vitamin D therapy, with rare exceptions, and one of these exceptions is pregnancy through to around 6 months postpartum, because this ensures that the baby is also getting a good grounding of vitamin D level. So what's the function of vitamin D? So it regulates your immune function, regulates your blood pressure and your cardiovascular health, regulates your muscle composition and muscle function, and also your bone health, your calcium and your phosphorus. So it's a very important vitamin, it's a very important chemical, and certainly in terms of falls, if we have poor bone health, poor muscle health, that's going to increase the risk of falling. So vitamin D is necessary for adequate absorption for both calcium and phosphorus. So these are bone hardening materials, and it allows for the proper function of the parathyroid hormones to maintain those calcium levels that are required for bone hardening. There is a positive relationship between vitamin D and a low BMD in the hip and the spine. And one study found that having low levels of vitamin D was associated with an increase in mortality in the general population. It also regulates these other conditions, so it does help to regulate type 2 diabetes, hypertension, coronary heart failure, osteoporosis, multiple sclerosis, mood stability, which we'll talk about in a bit, and some types of cancer might be prevented, although this isn't very, very clear. The literature does differ, but all seem to note that there are benefits of vitamin D. So what's the physiology behind it? So pre-vitamin D exists in the epidermis layer of the skin and is converted to D3 upon light exposure. It still requires two chemical processes until the body can actually use it. So the sun hits the skin and it starts to trigger that synthesis. Heads to the liver where it's hydroxylated and it converts to calcidol. Hydroxylates again in the kidneys and forms active calcitrol. So now the body can use it. And it heads from there to all the vitamin D receptors within your body. So you have vitamin D receptors in the brain, the heart, the skin, the gonads, the prostate, the breast, the bowel, the bone, the kidney, intestine, and it then it activates that vitamin D and it leads to the maintenance of the calcium and phosphorus in the blood, which helps to maintain all of the systems and to maintain bone content. So signs and symptoms of vitamin D deficiency, there's many of these. This is just a few of them. Frequent falls, muscle aches, depression, fatigue and chronic low energy, impaired cognition, frequent bone fractures and bone pain, and asthma in children, and possibly stunted growth in children too, which is where the rickets comes in. So very briefly about rickets, because rickets are still around and just need to be aware of it. Although in Australia it's very rare, fewer than 10,000 cases a year, but that means it's still happening. It's a skeletal disorder that results in soft and weak bones in children due to vitamin D deficiency. The symptoms, there's a few symptoms, but the main ones are bone pain and tenderness, poor growth, bow legs and knock knees, increased curvature of the spine, and you may get these nodules as well upon the rib cages. Treatment is chocalciferol and calcium carbonate. It is possible to get hypervitaminosis. It's rare, but it's possible. So this can cause high blood concentrations of calcium, which will then lead to overcalcification of bones and soft tissues, heart and kidneys. And it can actually appear several months after excessive doses have been administered. So there was a time when large doses of vitamin D were given every 6 months. And they found this hypervitaminosis would occur a few months after these doses were administered. And it could also be because this medication was synthetically made, and that could be in causing this. Low calcium diet and corticosteroid drugs allowed for a full recovery within a month. It's unlikely to get this if chocalciferol is administered. There's a very large safety window, safety net, and exposure to sunlight, there is no risk of vitamin D toxicity. It is only from excessive doses. So definition of vitamin D: severe deficiency is less than 12, sufficient is 50 and above, and elevated is over 250. So who is at risk of vitamin D deficiency? There's people with certain skin conditions who need to avoid the sun. There's people with dark skin, people with diseases which make it difficult to absorb enough of the vitamin, for example, celiac disease. People that have limited access to sunlight because of disability, illness, working conditions, shift work. People who are housebound, those over 65 years or are resident in aged care facilities. People who cover themselves for religious or cultural reasons, and then people who follow vegetarian and vegan diets, although that's a minimal because you only, as you'll see in a minute, you only get around 10% of your vitamin D from your diet. Most of it comes from sunlight. So how do you reduce the risk of deficiency? You go for walks before 10 a.m., after 3 p.m. A diet will provide 10%, as I said, of your vitamin D needs. Sunlight exposure will provide 91% of your vitamin D needs. And here in Perth, between before 10 and after 3, 5 to 6 minutes at the height of summer is all that is required. And you don't need to put your cosy on and go outside and lie in the sun. It just needs to be your face and your hands. And in the winter, because sunlight and the UV is weaker, 15 minutes in the middle of the day is optimal time. Then look at your diet. So oily fish is always good, and canned tuna and salmon certainly will suffice. Cheese, meat and egg yolks, and fortified products. So what does the literature say? So let's look at this literature. Going to first touch on vitamin D and COVID-19. So the early clinical evidence indicates to us that there is an increase in vertebral fractures, hypocalcemia, vitamin D deficiencies, and a loss in BMD among COVID-19 patients. And additionally, a lower BMD is associated with a more severe COVID infection. Part of this is considered to be mechanical unloading that may occur with severe disease. So, for example, when you're extremely unwell, this may be due to be with bed rest. You may not be eating as well. You have muscle wasting, and that's shown to occur with COVID infection. That will increase the risk of somebody falling. Medications used to treat SARS-CoV infection also have a negative effect on the bone, increasing the risk of a fracture. And SARS-CoV infection can also worsen conditions such as diabetes and negatively affect kidney function, all of which would contribute to bone loss and increased fracture risk. So COVID itself can negatively affect the bone through multiple direct and indirect mechanisms, increasing the risk of somebody of falling and harm from falling. But vitamin D supplementation might actually boost the immune system of COVID patients and reduce the severity of the disease in vitamin D deficient individuals. So does this mean that when patients come in with COVID, should we be checking their vitamin D levels and temporarily supplementing? There's a significant direct association between vitamin D deficiency and elevated risk of COVID-19 in hospital mortality. And each unit increment in serum vitamin D levels was associated to reduce the risk of COVID-19 mortality. So there is a highly suggestive association between vitamin D3 supplementation and reduced severity and mortality among COVID-19 infected patients. How does this look in practice? Should we be considering giving patients that are infected with COVID-19 a short course of vitamin D3? More trials are required. The role of vitamin D in preventing and/or treating long COVID does need more trials, but there is promise there with the trials that have already been run. In November last year, WA Health and the Older Adult Health Network released a position statement on COVID-19 and falls prevention. This is about wanting to raise awareness about the consequences and long-term impacts of the COVID-19 pandemic on the risk of falling, particularly for older people, and options to respond to this. In addition to the immediate health effects that COVID-19 has, the COVID-19 pandemic years themselves have had a significant impact on the health and well-being of older adults. This does include, from literature we know that this includes an increased risk of falling and injury. And there may well be fear of contracting COVID-19, which ensures that there is a reduced physical activity and concern about falling and social isolation. So what the position statement does is it provides health professionals with more information, but also some actions that they can take within their own practice to identify patients that are at risk because of COVID-19 or because of the pandemic, and options of what they can do to put interventions and strategies into place. So vitamin D and muscle function. So higher vitamin D levels to be associated with a better tug performance. And in the community dwelling older Australian women, maintaining a vitamin D level of 75 and above can confer benefits to muscle function and long-term prevention of injurious falls that require hospitalization. Monthly high-dose vitamin D supplementation does not reduce the risk of falling, and as said before, it really needs to be a daily dose. There is a possible increased risk of falling with supplementation in people who have a normal BMI, but that needs further investigation. There was nothing concrete about that. Intermittent single high-dose vitamin D supplementation had no preventative effect on the risk of falls and fractures and might even increase the risk of falls. So again, it's that daily dose. In a country such as Australia, where we have sun all the time, vitamin D deficiency can contribute to a considerable number of hospitalizations as a consequence of falls and for the treatment of hip fractures in older Australians. However, with diabetes, the use of specific vitamin D supplementation to increase the risk of falling among patients with diabetes. So if it's not indicated in somebody with diabetes, it probably is not advisable to provide vitamin D supplementation. So bone loss. Preventing bone loss and that information about osteoporosis should be given from an early age so that it's looked at and discussed and talked about and educated about from childhood through to late teens. It means that maintaining a healthy lifestyle, optimal intake of calcium and vitamin D, proper nutrition, exposure to sunlight, etc. Proper education on avoiding risk factors like smoking and caffeine, and awareness of bone health that should continue through life. But that message needs to be given again to women who are heading through menopause, because that's when increased bone loss is expected. So with oral health, vitamin D level affects masticatory muscle activity, believe it or not. So by improving, if you have somebody who's not eating very well or they're very tired when they're eating, perhaps check their vitamin D levels. Because by improving the vitamin D levels, it improves the thickness of the masticatory muscle and boosts its tonicity. And this study recommended that vitamin D therapy should be an adjunct to nutritional counselling. Vitamin D should be combined with calcium because that's what helps to reduce the fractures in the older population. And daily low-dose vitamin D regimes reduce the risk of falling. Supplementation decreases the risk of progression from pre-diabetes to type 2 diabetes, and supplementation is the most effective and practical in aging populations. So don't go for sunshine, don't go for a diet. Supplementation is the best. In patients who have systemic lupus erythematosus, SLE, low vitamin D was associated with a higher disease activity and with an increase in serum vitamin D levels. This was associated with a reduced disease activity over time. And the therapeutic effect of vitamin D in SLE really does need further assessment. So some of the receptors in the brain are vitamin D receptors. And so somehow vitamin D is acting in the brain. And researchers have found that these receptors are found in the areas of the brain that are actually linked to the development of depression. They're not sure how this works, but they're trying to look for that link to see what could be done. The studies are being conducted mostly at Norway and Finland. Sickle cell disease, there is a Cochrane protocol which determines the effect of vitamin D supplementation or how much should be given to children and to adults. Vitamin D deficiency is very common in those who have sickle cell disease. Supplementation for both adults and children can reduce the severity of an episode, but there are still more studies that are required. So do you screen or not screen? Tests for vitamin D deficiency rose sharply between 2000 and 2001, and the cost to Medicare increased from 1.1 million to 95.6 million in 10 years. It peaked at a cost of 151 million in 2013. So changes were made to Medicare and the number of tests that were being completed were reduced. But in 2015 to 2019, it was noted that testing was beginning to rise again. It increased by 34%, and the cost rose 42% from 73 million to 104 million. So what the government says is that patients at clear risk of deficiency could simply be treated without actually being tested. Only those at risk, but if at risk, supplement anyway. Remove the screening test. Residential aged care should be supplemented. Symptoms, lifestyle, risks should all be taken into account. This is a conversation that you have with your patient. More advice does need to be given about sun exposure. Literature states that there is confusing messages when we talk about sun exposure and vitamin D. Should we have sunscreen? Shouldn't we have sunscreen? When's the best time of day? How much skin needs to be exposed? So they consider that the messages are very confusing. Should focus on bone density maintenance from childhood. and more consideration for women entering menopause and the potential need for supplementation. It's about being proactive. It's about taking action now that will have its benefits later on in life. So there are very mixed studies as to whether sunscreen blocks the formation of vitamin D or not, but this is a fairly new sunscreen that enables the body to still produce vitamin D. There's various apps and there's watches which will tell you about the UV light. So what about the medication? So daily requirements 800 to 1,000 international units, and cocalciferol is commonly used. Multivits, they really only have 200 international units per tablet, not adequate to treat or prevent vitamin D deficiency. And calcitrol, generally not suitable, very narrow therapeutic window, and it increases the risk of hypo and hypercalcemia. So consider the patient. So low vitamin D can contribute to falls. There's very clear literature about that. The receptors are present in your muscle tissues and in your bones, and so if it's not getting enough vitamin D, then your muscles are going to weak, your bone density is going to decrease. So you need to consider your patient. Are they a frequent faller? Are they residential aged care resident? Are they an older person who is bedbound or housebound? Check the bone mineral density algorithm. Should they have a DEXA scan? Should we be checking bone health? Assess the risk factors and the symptoms of vitamin D deficiency, as well as all the falls risk factors. Consider other high-risk patients and whether they should be supplemented or not. With your menopause, please check with your GP. Consider supplementing without testing. And long COVID and COVID. There is clear information about COVID and about vitamin D deficiency. Precision clinical trials may be the only way to prove the benefits of vitamin D supplementation. There have been many clinical trials that have occurred, and some of them are more than adequate to prove the benefits of supplementation. Thank you.